Hi, my name is Andrew Van Lint and I'm a Haematology Registrar. This talk is about an orientation for sixth years and interns into how to manage bleeding issues and anticoagulants and reversing those anticoagulants and a few other issues that you might encounter as a junior doctor in a hospital. I'm going to talk a bit about the iTransfuse app and how useful that is, and that will really solve a lot of your issues so you don't have to refer to guidelines. I'm going to talk a little bit about anticoagulants and how to test them, how to reverse them. We're going to talk a little bit about how do we manage peri-operative issues, when to stop and restart antiplatelet and anticoagulant drugs. Talk briefly about the many potential causes of thrombocytopenia, which is a really common issue in acute medicine and surgery, and how to diagnose or work up a query lymphoma or myeloma, which is what we'll finish with. So a couple of things to go on with first. The iTransfuse app, highly recommend this from Lifeblood, formerly the Red Cross Blood Service. This is fantastic and it replaces a lot of the cards that you might have on your lanyard or other kind of thing with your ID card. So in terms of prescribing blood, in terms of Warfarin reversal, which is what I use it regularly for, and in terms of managing transfusion reactions, it's such a helpful resource. It's for free. You can download it today from Android or for iPhone. Couple of really key messages that I'd love to get across in this talk. And the first one is that anticoagulants do not cause bleeding. A lot of people say, oh, they're bleeding because they're on an anticoagulant. That's false. Bleeding happens for other reasons, and it's always important to actually define or investigate, why is this person bleeding? If it's a GI bleed, you can't just put it down to the anticoagulant. You need to look at and potentially do an endoscopy or other to find out why they're bleeding, because anticoagulants make the bleeding worse. They don't actually cause bleeding itself. And then in a similar kind of vein, reversing an anticoagulant doesn't actually stop the bleeding. Again, the bleeding is happening for another reason. It might have been clinically insignificant, and because they're an anticoagulant, it becomes clinically significant. Reversing the anticoagulant is a really important step in their management and will definitely reduce their transfusion requirements, but they still need to have the actual issue addressed. So reverse the anticoagulant at the same time that you're investigating and ideally managing the source of their bleeding. So important to do that. So let's move on to anticoagulants. So what is safe, and what are the things that we use a lot here in Australia, and particularly in the South Australian context where I work? We still have Warfarin, comes in Coumadin and Maravan. It's very important you stick to whichever one the patient's already on. We have heparin infusions. They've been around for a long time. They require a lot of close monitoring and adjustment, but they're often used in acute situations because of their rapid reversibility. Enoxaparin is the most common low molecular weight heparin that we use. And again, there's a very safe option with a high degree, although incomplete reversibility. So we see that used a lot. Then we have our, what used to be called the NOACs, we now call the DOACs, the direct oral anticoagulants. So apixaban, which is a BD dosing, and rivaroxaban, which is daily dosing, they're our anti-10A agents. And then we've got dabigatran, which again is twice daily dosing, and that's an anti-thrombin or anti-2 agent. And really between those six, they're the common ones that we use, and there's not many used outside of that context. So when you're starting an anticoagulant, there are a few things. If you're using it for a clot, or if you're using it for atrial fibrillation, there's slightly different ways of managing it. The dose that you end up on is the same, but initially if you're treating it for thrombosis, they essentially have like a loading period. So if we take apixaban, which is usually my DOAC of choice in my practice, you actually have a week of 10 milligrams twice a day as this loading period, and then you go on to 5 milligrams twice a day, which is what the maintenance dose, and the same as if you were having atrial fibrillation. There's a few factors that might lean you towards using the reduced dose, but effectively they're getting double dosing for a week if they have a clot. And then rivaroxaban has a similar kind of story. It's usually 20 milligrams a day as a standard dose. And then in the first 3 weeks, they have a loading period where you give 15 milligrams twice a day if you're giving it for venous thromboembolism, so it's a PE or a DVT. If you're giving it for atrial fibrillation, you just start them on a 20 and go with that. Enoxaparin has a different kind of dosing regimen. So typically, if they've got good renal function, we're looking at 1 milligram per kilo twice a day, which is usually the starting dose, and then transitioning, if you prefer for convenience, a once a day dosing of 1.5 milligrams per kilo. If you are using enoxaparin initially for treating, for example, a PE or a major DVT, we often will count the enoxaparin as part of that loading dose. So if they've been on enoxaparin for a week and you put them on apixaban, it's often reasonable to go straight onto that 5 milligrams BD. The other benefit of using these kind of anticoagulants, they're interchangeable. So if you're on enoxaparin BD and you're switching to apixaban, you can literally just replace the next enoxaparin dose with apixaban and the same for rivaroxaban. So you can interchange these as long as you keep the normal dosing schedule in place. Starting warfarin is a lot more complex. So there's a few things that are really important that I think still apply to a lot of other anticoagulants, but particularly warfarin. You need to document your indication. So is this for a mechanical valve? Is it for atrial fibrillation? Is it for a VTE? Is it for an arterial thrombus? Whatever it is. And then put your target INR range, which for most things is typically going to be 2 to 3. And for some mechanical valves, it's going to be 2.5 to 3.5. And there's a few valves that have slightly different ranges. So if you're not sure, actually check with the team that managed the insertion of the valve. At the same time, it's so important to start enoxaparin at 1 milligram per kilo twice a day if their renal function is okay. It's important because we've made a commitment to anticoagulate this person to prevent complications. And so we give the enoxaparin firstly because we're anticoagulating straight away. And secondly, we give it because when you load warfarin at high doses, it depletes protein C before it depletes other procoagulant factors. And so because it depletes protein C, they actually become more prothrombotic for the first maybe 24 to 72 hours before they become anticoagulated. And that's a lesser known thing. So that kind of bridging clexane is the term we often use, is so important, not just because you're bridging their anticoagulant status, but also because you're covering that protein C deficiency. So you can load them according to a protocol. There's a number of different protocols according to the area that you're working in, so please refer to your local guidelines. And then you stop the enoxaparin usually when their INR is above 2 for 1 to 2 days. There are a lot of services like Hospital at Home and others that allow you to start or initiate the warfarin as an inpatient and then quickly transfer them to community as you titrate the doses appropriately, then stop the enoxaparin and hand over to your primary care doctor as your GP. There are a number of reasons why we might test levels. And in terms of warfarin, we use the International Normalized Ratio, or the INR, which is derived from prothrombin time. So if you're ever wondering, why do I always get a prothrombin time with an INR? They go hand in hand. The INR is a value that's derived from the prothrombin time. So if you're initiating warfarin or you're starting a new medication that might interact, or the person is particularly unwell, it's important to test the INR daily as an inpatient. And once they're stable and they're maybe staying in for other reasons, you probably test it weekly or twice weekly at that period. So be particularly aware if they're changing their diet or they're changing their medications, there may be cytochrome P450 interactions that will actually inhibit or induce the clearance of the drug, and that's an easy trap for new players. If you've got them on a heparin infusion, you need to use their APTT, and that's usually tested every 6 hours initially, and then once they're stable, every 24 hours. There's a number of other tests that we now have available routinely for testing drug levels of our newer agents, the DOACs, and they're generally anti-10A activity assays. But when we're asking for this, generally it's easier to request a drug level of the drug that you're using. So if you're using enoxaparin, you can request a low molecular weight heparin level, and that value is derived from an anti-10A assay and then a calibration curve that's specific to that drug. So it's so important that you actually say what the drug is that they're on when you're requesting that level. Likewise, apixaban or rivaroxaban, you're asking for that level, but they're deriving that level from a calibration curve and an anti-10A activity assay. The peaks that we usually use for those medications, both low molecular weight heparin and the DOACs, is a 4-hour peak, and then the trough according to their dose. So essentially the trough is a level taken just before you give the next dose. So if you're on a 24-hour dosing regimen, it's ideally at 23 to 24 hours. And if you're on a 12-hour dosing, it's at 11 to 12 hours as a trough. It's important also to note that although we can check effectively these levels, it's not quite like INR is or APTT is with heparin and warfarin. It really tells you the drug level, and it's not yet validated for clinical correlation. So it just says, is the right amount of the drug that would usually give the right amount of anticoagulation effect. It's not directly measuring the anticoagulation effect, and that's an important context to realise. Let's talk about peri-operative management of antiplatelet and anticoagulation agents. So there's going to be a lot of situations as a junior doctor where maybe in a pre-admission clinic or for your admitted patients, you need to plan what to do about their aspirin or their clopidogrel or their ticagrelor or their enoxaparin or their apixaban when planning for a procedure, maybe the next day, maybe a few days later, maybe the next week. So generally it's good to think about, let's check what agents they're actually on. Some people are on multiple agents these days, and then to determine what is the risk in terms of bleeding risk of the procedure. So it's a less invasive procedure, then it's going to be more of a low risk. If it's more major surgery or something that involves going near to major vessels, then you're going to think that's a high risk of bleeding. And there's going to be some situations as well, we're going, this is emergency, they've come in, they're on an agent, they've had, there's a traumatic complication, and we need to operate within, minutes or hours. And so that's another context there. And the last context to consider, when can I recommence the agent afterwards? So let's run through a few of those. So let's say your patient is on aspirin or a similar antiplatelet agent. For a low risk, you're thinking 5 days holding prior. And if it's a high risk, then probably 7 days. So if you're not sure, 7 days is a pretty good way to go. In terms of emergency situations, we'll often have to go for surgery regardless. And in issues where you're really concerned about bleeding, then usually giving them 2 units of platelets immediately pre-operatively will help manage the risk of the antiplatelet agent being still active. And then we generally recommence them 24 to 72 hours after the procedure, and we usually reload them at that time. So if they're on aspirin, they'll often get another 300 milligrams and then go on their maintenance 100 milligrams. In terms of warfarin, it's a bit more standard. Regardless of the risk of the procedure, warfarin is a bit more risky generally. So we generally hold it 5 days prior, and for some a whole week. And then a day prior, we need to check what is their INR. And if the INR is still elevated, we'll often give some vitamin K to reverse it quickly. And if it's an emergency situation, you can refer to your local protocols or your iTransfuse app, which will actually tell you exactly what to give in terms of vitamin K, prothrombin complex concentrate, which is Prothrombinex in Australia, and in some situations when to use fresh frozen plasma. And then we generally recommence that 2 to 3 days after the procedure. Enoxaparin can be held 24 hours prior to a low-risk procedure, but if it's high risk, it's going to be 36 to 48 hours. In those situations, it's also important to look, is their renal function still stable? Because if it's got worse, it might take longer to clear the drug. If it's in an emergency, generally, you probably need to call a critical bleeding specialist from Haematology, and we generally recommence this 1 to 2 days afterwards. The DOACs follow a very similar kind of style, generally holding them 2 days prior, or for a high-risk procedure, 3 days prior. Again, if their renal function is impaired, they might need to be held a little bit longer prior, and you can always check the drug level in that situation immediately prior to the procedure. In terms of emergencies, again, give Haematology a call and we'll tell you what we can do. There isn't any specific reversal agents for some of the DOACs, but there's still a lot of things that we can give to minimise the risk of bleeding during the procedure. And we generally recommence them like enoxaparin 1 to 2 days later, depending on bleeding risk. So if you're really not sure, then call Haematology. And if you've got someone that's on warfarin, for example, for a mechanical valve, or they've had a recent stroke, that's the kind of one that you should think about bridging Clexane, and also maybe think about a formal peri-operative or haematology consult to best guide how to manage that risk. Thrombocytopenia and how to manage that around a peri-operative patient. In terms of surgical targets, we get a lot of calls, and from a haematology perspective, we always recommend if you're performing an invasive procedure or minor surgery, 50 is a good target in that situation. If they're undergoing major surgery, so open laparotomy, anything to do with cardiothoracic, and anything to do with neurosurgery, we would generally recommend 80 and above. There are some surgeons that have very specific guidelines for a bit higher than that, sometimes up to 100. But for most haematology advice, we'll usually say 50 for minor and 80 for major. And you can use transfusion to get you there. In terms of when to stop medications, because a lot of people will drop platelets and then you're saying, should they still be on an antiplatelet at that level? Should they still be on their anticoagulant, whether therapeutic or prophylactic? So we generally say if you're getting down into the 50 to 80 range, we should think about holding anticoagulants and antiplatelet agents. I think particularly once you drop below 50, very few people would argue that you should still be on those agents. In terms of prophylaxis, you could still be on a prophylactic dose, and if you're concerned, you could drop them when they drop below 50 to a prophylactic Clexane dose if they're usually anticoagulated. But if you're getting down below 30, there would be very few people that would recommend being on any level of prophylactic or therapeutic anticoagulation, and definitely not any antiplatelet agent at that point. In terms of transfusion, we generally find for platelets, you would expect an increment, so an increase of about 20 for every bag of platelets that you give, or unit. So if they are below 30 and they're actively bleeding, you should definitely give them platelets in that situation, because it probably says the few platelets are on board are not maybe working properly because of other factors. If they're particularly unwell, and particularly if they're febrile or they have a high risk of bleeding, think of transfusing people that are in the 10 to 20 range. And then for most people, if they're dropping below 10, you should transfuse them even if they look pretty stable. If you're trying to investigate a new malignancy, you'll often be under a general medical or surgical team that says, oh, I'm a bit concerned this person has hypercalcemia. Do they have myeloma? Or you might be on a renal team who says, oh, their renal function is getting worse. Could this be a myeloma or cast nephropathy? And likewise, other situations we go, oh, they've got a lymphocytosis and some unexplained fevers. Could they have lymphoma? So if you're thinking acute leukemia, you're probably seeing that they are pancytopenic, they may have an active infection, and there may be peripheral blasts reported on their film. We want you to call Haematology straight away, and hopefully we already know about this, but they're the ones, just call us and we'll take over at that point. In terms of lymphoma, there's a few things that need to be looked into because many things can appear like lymphoma, but not all of them are lymphoma. So performing a complete blood exam, looking for lymphocytosis and biochemistry, including urate, to look for a raised LDH or raised urate, which may kind of determine their risk or activity of tumor lysis syndrome. We then look for CT staging. So this is generally a neck, chest, abdo and pelvis CT, not usually the brain, unless you have concerns there. And then we aim for, the gold standard is an excisional biopsy of a lymph node that looks involved or is enlarged. But otherwise, I would get a core biopsy via ultrasound or CT is a reasonable alternative. It's really important not to do a fine needle aspiration because you won't get the diagnosis that you're looking for. And then what usually happens after that point is that haematology gets involved. We do a PET scan, which is really important for staging, and then we'll usually do a gated blood pool scan or an echocardiogram, and that's really planning for chemotherapy. So that's your standard workup for almost every type of lymphoma. Some of them will get a bone marrow biopsy as well, but we'll take care of that as haematology. In terms of chronic leukemia, a little bit easier. We mainly do this, and what you're thinking is chronic lymphocytic leukemia is most of the cases here. We're looking at flow cytometry, or immunophenotyping is the other name, and you can diagnose people essentially with CLL just on flow cytometry if it's pretty clear. And then we would usually do CT staging, as some of CLL and lymphoma have a lot of overlap, and so one can look like the other. If you're thinking they might have chronic myeloid leukemia, we still do flow cytometry, but we'll also look for the BCR-ABL protein, which is a specific test you can order. Let's move on to myeloma now. There's a particular clinical activity criteria for myeloma, which is called the CRAB criteria, and they are hypercalcemia, renal impairment, anemia, and bony pains. Obviously, myeloma is a condition that's more common as we get older, and renal impairment and anemia and general pains are pretty common as we get older as well. So some of these things can be difficult to actually differentiate from other issues going on in general aging. So we do a CBE in biochem, we're looking for anemia and obviously renal impairment. We're looking for raised globulins that would imply they might have a paraproteinemia. We do either an X-ray or a CT skeletal survey. CT, it's low-dose CT of the whole body, looking for those myelomatous lytic lesions that are so characteristic of the disease. And then there's a few things that we look for the secretory evidence of myeloma, and they are paraprotein, which is protein electrophoresis, the serum-free light chains, beta-2 microglobulin, and a Bence-Jones protein in the urine, which is not always essential, but many of us still do that. And then finally, that's when you call haematology and say, look, I've got decent evidence to suggest they've got myeloma. Could you see this person? Could you consider bone marrow biopsy? And we'd be very keen to see those patients. If you're investigating a new thrombocytopenia, there are a huge range of disorders that might be causing it. So if you are generally getting below 100, you should think about investigating, but 100 to 150, there's a lot of things that are reasonably benign or secondary that you wouldn't need to worry too much about. Some of the key things I would look at doing, definitely ordering a blood film, definitely CBE obviously as well. And then the less commonly known one is the immature platelet fraction, or an IPF. And this is essentially like a reticulocyte number in the context of a platelet. And it tells you, is the bone marrow responding to thrombocytopenia appropriately? Because if you're getting thrombocytopenic, the bone marrow should really increase its production of platelets. And we'll see that as a raised IPF that's appropriate and physiological response. If you've got a low platelet count and an inappropriately normal IPF, that says the bone marrow is not actually producing platelets, and that's going to be at least part of the problem. It still could be secondary. Sepsis and other inflammatory disorders and medications often suppress the bone marrow, but you also got to suspect, is there actually a primary bone marrow problem going on, like a malignancy or something similar? So I've included a range of different potential conditions. Some of the more serious ones will be things like TTP, thrombotic thrombocytopenia purpura, ITP, immune thrombocytopenia purpura, and disseminated intravascular coagulopathy, DIC. So a lot of them, the blood film and the CBE can give you most of the story, as well as extended coags. And whenever you're considering this person's maybe dropping their platelets quickly, get a group and hold, so then you can transfuse them if you need to by time. There's a couple of specific panels that will often get called, and this is where I want to finish. So if you're suspecting that they have hemolysis, so that's red cell lysis, a blood film and a CBE, you're going to look for anemia, and you're going to see some red cell fragments on the film. You look for bilirubin, which is typically elevated, haptoglobin, which is typically undetectable. So what's haptoglobin? It's a protein produced by the liver. So if you have liver disease, it will be reduced, but it won't be undetectable. And haptoglobin binds to free hemoglobin and then takes it out of the circulation, so it doesn't cause any tissue inflammation. So generally, if you are having any significant amount of hemolysis, the haptoglobin will be consumed and therefore undetectable in the serum. And the last thing that you're going to do is the direct antiglobulin test, or a DAT. If you've heard of Coombs test, the DAT is the kind of modern equivalent of the Coombs test and still uses a lot of similar techniques. And that's going to tell you whether there's an immune process at work that's causing hemolysis, or if that's negative, then you're going to think more of a mechanical hemolysis from a few other causes. If you're thinking that someone's had an unprovoked DVT or arterial thrombus, sometimes, and I think only with consultant or haematology input, you would order a thrombophilia panel. This costs about $240, so it's just, a decent investment, and it's not something we want to be ordering for any patient anytime that they've had a clot. They include factor V Leiden and prothrombin gene mutation, which are probably the more common but less severe thrombophilias. Protein C deficiency and protein S deficiency, which are generally kind of a moderate risk thrombophilia and generally hereditary or congenital. Antithrombin deficiency, which is a much more severe condition, and then antiphospholipid syndrome, which can be associated with lupus. That is generally acquired, and in some people they have had it their whole life. There's a few specific conditions to consider there. If the patient is already on an anticoagulant agent, particularly things like warfarin, but even enoxaparin and DOACs, some of the tests here, particularly things like protein C and protein S, may be reduced by the actual drug. And for DOACs, it can actually give you a false positive lupus anticoagulant. So it's just important to consider, and if you're ordering these tests, please do write patient currently on apixaban, patient currently on warfarin, whatever it is, and then the lab will be able to interpret them in that context. And we're actually working on some techniques that would allow us to take some of those drugs out of the serum and then test them without that drug being active. So that's pretty cool. So that's my tips and tricks for haematology for interns, and definitely relevant to junior doctors and 6th years or final year students. I hope that's really helpful. And really, if you're not sure, give the haematology hotline a quick call. Thanks for listening.